Salam alaikum. Good afternoon, everyone. Welcome to the Grand Rounds. Today, we're pleased to have a special person. He is Professor Abdulaziz Sawad. When we talk in Saudi Arabia about pediatric ophthalmology and strabismus, his name appears as one of the main actors in the development of the specialty in the kingdom. Mentor, trainer, teacher of many generations of pediatric ophthalmologists. His legacy has been spread in this country and beyond of our borders. Clever, gentleman, with a deep knowledge of the field. He's capable to summarize with his words a wisdom message with less than 100 characters. So definitely he's better than Twitter. Dr. Awad, I don't want to waste more time with my words. Simply, Kekesh is honored to have you today with us. The mic is yours.
Thank you very, very much, Professor. I'm not really sure I deserve all of this really compliments. And it's really a humbling experience to be, a member of a division that you lead. It's certainly my honor and my pleasure to be a member of your division. Thank you very much, everybody. And it's certainly my honor and pleasure to be here today and talk to you about a subject that is gaining increasing, importance and popularity. Certainly in the past, 2 years of COVID-19, almost every month we do see as a webinar in one way or another is related to pediatric cataract surgery, etiology, what have you. And today, what I will do is really, I will focus on the surgical management of pediatric cataracts. I have no financial disclosures at this moment in this presentation, just for your information. And when we talk about pediatric cataracts, it's really important for us to remember that cataract accounts for the most common cause of treatable blindness in children worldwide. And the incidence varies, depends on what you quote, between 1 up to 6 per 10,000 live birth. The origins varies, and to be very honest and frank with you, even today, 60% of the cataracts that we see in children, we don't really know an etiology for it. So really, there is really a big room for Nobel Prizes to find the origins of a significant number of pediatric cataracts. Genetically, related conditions with cataracts account for 30 to 40% of the cases. By the way, all these QR codes that you are seeing on the screen are active, and you can really, shut them and get to the reference publications. Here is a good reference for etiology of pediatric cataracts. As you can see, in both unilateral and bilateral cases, the majority are unknown. There are known syndromes and systemic associations, and trauma is also an important cause of pediatric cataract. But a good percentage, as I said, up to 60% is actually still unknown etiology to us. In general, when we talk about pediatric cataracts, we aim for a better visual rehabilitation. And this is really, encompasses an early intervention, surgical intervention, a good surgical technique and handling of the patient's eye, and immediate visual rehabilitation. And what it really takes, to achieve all these three, important factors is really, an individualized care to each patient. And, a dedicated, experienced team. To be very honest and frank with you, the most important member of the team is the patient mother. If you really succeeded to get her engaged into the care of the child, I assure you that you will have the best outcome. Here are some important remarks to remember. How does pediatric cataracts differ from an adult cataract? In children, a cataract does not only blur the retinal image, but it also disrupts the development of the visual pathways into the central nervous system. And unfortunately, delay in the management of the visual rehabilitation of pediatric cataracts can result in a permanent and irreversible visual loss. This is really, stresses the importance of early intervention with the proper, surgical techniques, and the optimal visual rehabilitation post-operative, as we said. When we really talk about surgical management, patient age is a very important factor, the type of cataract and the laterality. All of these really, determines, are important determinants for the outcome of the surgical procedures. Few important things to remember when you are really doing cataracts in children that makes them a little different in terms of the surgical techniques. The anterior chamber instability is a major and an important challenge that you should really keep in consideration. The increased capsule elasticity, and I talk about capsule here, I mean the anterior and posterior capsule, because as you will see, we have invariably to handle both of them. And the decreased scleral rigidity, all of these really makes it a little bit more challenging to do pediatric cataracts, especially for those who are not used to it or for junior colleagues. Let's go directly into the surgical procedure, and we start by the incision. Allocation of the incision is important, and several approaches can be taken. Like a superior approach is more protective by the brow and the pelvis phenomenon, easily made, and is the choice of more than 80% of the ABOS members, the American Association of Pediatric Ophthalmology and Strabismus. If we go to the steepest meridian, we are really going for refractive procedure. Yes, it does decrease the surgical induced astigmatism. And however, we should always remember that, a child eyes is growing and astigmatism could also change. A temporal approach is much more convenient, however, is much more prone to trauma and is much more exposed. When we choose a scleral versus a corneal, when we choose a corneal incision over a scleral incision, by doing so, we are avoiding the conjunctival parotomy, avoiding potentially hyphema, easier interoperative maneuvering, a better cosmesis if further filtration surgery is needed. If further filtration surgery is needed, you have saved the conjunctiva for yourself or for your glaucoma colleagues to do the filter. And, the patient is on anticoagulants, you avoided touching any, potentially bleeding structure. However, there is more surgically induced astigmatism with corneal incision. The risk of endophthalmitis is probably a little higher, and endothelial cell loss is higher, plus delay in healing. All of these, one would really like to take in consideration when we are planning to do the surgery. And as I said, the more we individualize our care to our patients, the better will be our outcome. Paracentesis is actually a very useful, in cataract surgery in children. It allows us to do a bimanual maneuvering, which gives us access to the whole capsular bag, 360 degrees without any hassle. It helps in stabilizing the globe, and it facilitates the implantation of the intraocular implants. And if iris hooks are needed, it would actually be helpful to have them. Just to remember, the difference between the various, probes that are available for us. A 20 gauge probe and a 23 gauge probe. A 20 gauge probe is probably a millimeter, 80% of a millimeter, while a 23 gauge is a 58% of a millimeter. If we aim really for a stable chamber, especially in a small eye with probably poor dilation, probably a 23 gauge is our choice. And it generally said the less you open, the less likely you will go into complications. The prosthesis, we can really choose the location, the length and width of that, and whether we are going to really close or not, as you will see in the further into the talk. Anterior capsulotomy. Anterior capsulotomy is a very important, part of the procedure. I know that many surgeons might think that these are congenital cataracts and you are anyway going to open the posterior capsule. So, it's not really important. They might, promote that it's not really very important to do a good capsulorhexis. I would like to tell everybody, tell myself first, is that every cataract in a child, if not implanted as a primary, with a primary intraocular lens implantation, is, going to need a secondary implant. So we should really aim to prepare the place for the implantation of a secondary implant. And the more careful our primary procedure, doing a capsulorhexis or capsulotomy, a good anterior capsulotomy with the various techniques as we'll see, the better, will be our, position in either implanting as a primary or a secondary intraocular lens. What makes anterior capsulotomy different from an adult, anterior capsulotomy is that the capsules in general in children are extremely elastic, and you'll see in the videos later. It requires a high fracture toughness. Positive vitreous pressure due to the reduced scleral rigidity makes it also, more challenging. And the visual, difficult visualization sometimes, makes it really difficult to, the surgeon to achieve what he is really aiming for. Mydriasis may or may not, poor pupillary dilation may or may not really be a contributing factor. And the tendency for runaway or extension is actually quite significant. Several techniques, having said so, can be utilized to do anterior capsulotomy. In general, we prefer the manual continuous tear capsulorhexis. However, can opener can be used in certain situations, especially if the capsule is really abnormal with a scarring. Vitreorhexis can be also used. Bipolar diathermy frequency or the Fugo plasma blade. All of these can be utilized. And, we aim for the manual continuous capsulorhexis. However, if there are, special situations or abnormalities, one can opt to any of these to achieve the objectives. When we do the manual, continuous capsulorhexis, we aim for a 5 to 6 millimeter openings. And the trick is really to grab it and go to the center. That would really get you there. Here is another one where we have, an intumescent cataract, and after really inflating the chamber with good vesicular ovid, then, carefully, as I said, grabbing it and, directing ourselves toward the center would get you through a nice rhexis, which is really very important to aim for. As you can see, going toward the center is really the key for success. And then, either utilizing, a machine, like in this case, phaco probe for aspiration with zero power, actually. Usual setting is really a vacuum of 300 with an aspiration of 30, an intraocular pressure of 55 will get you there, and then, getting the rest of the cortex out. Here is something in a very young child with, a scleral tunnel incision. Only a few a month old, where the elasticity is at its max. I tried, to start my rexes, and I could not really get good visualization of the capsule. So I really painted the capsule, even after in the presence of Ovid inside the chamber. But look here, how much really I do have to exert of extension until I get my capsular rexes initiated, and then going carefully, around, completing my rexes. As I approached the end, I realized that my opening is small. I wanted to make it a little bigger. So I'm going again in a second round to make it a little bigger. In general, it's much better to have a small capsulotomy, anterior capsulotomy, and expand it, rather than have a large capsulotomy and run the risk of an extension where you would lose the advantage of having a good capsulotomy. Aspiration of the cortical matter can either be done coaxial, using coaxial technique with aspiration of a phaco machine, or a bimanual technique, which gives you the advantage of reaching to the whole capsular bag 360 without any hassle. Either technique can be used, and it depends really on the preference and on the situation. I must say, really, bimanual technique is really attracting more and more of my preference, and I'm trying to move from coaxial to a bimanual technique, where I really have the advantage of a stable chamber and the capability to reach to the various part of the capsular bag without any hassle. Posterior capsulotomy is inevitable, and anterior vitrectomy is inevitable in the majority of cases. The reason for that is that, almost every pediatric cataracts, especially in the young ones, they have a tendency to develop posterior capsule opacification, almost 100%. And actually, this could happen over days, not really weeks, because, the healing power of a baby eye is really tremendous. And the presence and the PCO is amblyogenic. The presence of strong vitreous phase and anterior vitreous phase act as a scaffold for the metaplastic epithelial cells, the equator and the pigment cells, and the exudate cell to form a fibrous membrane. This may need several YAG laser capsulotomies, and inevitably in the majority of cases needing surgical management. So primary posterior capsulotomy and anterior vitrectomy is really like, the way to go. And, likewise to the anterior capsulotomy, posterior capsulotomy can be achieved with either manual continuous curvilinear capsulorhexis technique, which is my preferred technique, or using a vitrector or a radiofrequency diathermy. I must say, really, I use all of these three techniques, depend on the case. And the way to do it is very easy, especially for, and otherwise, congenital cataract. After achieving, the aspiration of the, the lens matter, go around and do an opening into the posterior capsule, inject viscoelastics, and then go with capsulorhexis forceps to. There's a video that I wish I can play it. Okay. Anyways. The posterior capsulotomy that we have seen could be done before the implantation of the intraocular lens implant or after the implantation of the intraocular lens implant, where we as you can see here in the diagram, where we go, behind the intraocular lens implant and do a posterior capsulotomy and anterior vitrectomy. Intraocular lens implantation is probably an area of the most significant debates among pediatric ophthalmologists. For several good reasons, whether, to go for a primary implantation or secondary implantation, depending on the patient's age, the accuracy of biometry, the post-operative target of refraction, and the intraocular lens calculation methodology, and the selection of the intraocular lens implants. All of these are controversial areas. And, I'd be really delighted to hear your preference in the question and answer time after this presentation. These are some of the intraocular lens implants that are available here for us at KCASH, and we use most of them successfully. I must say, really, we have really moved away from heparin-coated PMMA lenses a long time ago. We are mostly doing single piece acrylic, Acrysoft in the bag implants, or a 3-piece, again, intraocular lens implant for the sulcus implantation for the secondary implants. As I said, all these QR codes are active, and you are really you're more than happy, would be more than happy if you scan them and go to the reference. In general, and it's really generally accepted that, a primary intraocular lens implants could be, considered, with confidence if the patient is a year of age and older. You could really think of doing it in an earlier, in a special situation. And this is really stresses what I said earlier, the individualized care of the patients. It's each patient situation is different, and accordingly, we could really tailor our management accordingly. As I said, foldable acrylic IOLs is getting increasing acceptance. 3-piece IOLs for the sulcus implantation or in the back. Various formulas, SRK2, Holidays, Hages, and you name it. The rule of 7, where we really target the post of refraction to be, certain amount of, refractive error can be really thought of. The rule of 7 is really increasing, acceptance. However, as we said, individualized care is really the rule. Here is, how to load and, implant the various intraocular lens implants. I've, collected them for you if you wanted to review. Suturing of your incision after cataract surgery is also is the rule. Only 2 to 8% of APOS members, left the incision and sutured, and most probably, they are dealing with older kids. Several reasons makes, the suturing is preferable because, tunnels frequently leaks in children. We do use steroids post-operatively more frequently because of post-op inflammation and, fibrinous exudates. Many times kids do not give us the opportunity to examine them properly in the post-operative period. And, the likelihood of a self-sealing wound is probably low, especially in children than less than, 10 years of age. Worth remembering that, with every suture, you run the tendency to induce astigmatism. If folds appear like this, you really know that you're inducing a 3 to 4 diopters of astigmatism. So one should be really careful. I must say, at the same time, the kids' eyes are very forgiving. Yes, you see them in the first post-op period having 4 or 5 or even 6 diopters of astigmatism, that 80% of it disappears in the second visit, which is like about two months after the procedure. Here's an example of how did cataract look like pre-op, and utilizing the technique of anterior capsulorhexis, posterior capsulorhexis, and anterior vitrectomy and centration in the back. How would they look like post-operative? Amblyopia is a very, very important determinant of the ultimate visual rehabilitation of the child with a cataract, and must be treated immediately. As I said, the most important member of the team is really like patient mother, who really is going to do the major part of this. In conclusion, pediatric cataract surgeries encompasses several different risks, the postoperative goals, and the long-term complications that are different from adult cataract surgery. Individualized care with multidisciplinary experienced team are the key for an optimal outcome. Anterior and posterior capsule surgery and anterior vitrectomy are essential steps in the surgical management of the majority of pediatric cataracts. I must say not all of them, especially posterior capsulotomy. But in the majority of pediatric cataracts, more and more realizing that I wish in the ones I have not done it in the time of the primary surgery, I wish I've done it, because posterior capsule classification is inevitable. Delicate and accurate performance of these guarantees a lower complication rates in the procedures and the fixation and the long-term clarity of the media. With that, I conclude, and I really, be more than happy to answer some of your questions if you do have.
Thank you very much, Dr. Awad, for the nice and wonderful presentation. I have a question. What do you think about multifocal intraocular lens in children?
Personally, I don't have any experience, but I've reviewed a few papers in preparation for this, grand rounds. Many, well-known authorities in the fields are recommending them for older children, 12 years and older. I think the concept is really like, good, and probably is really like more suiting to kids, because their world is really like a near world. However, as I said, the whole area of intraocular lens, choice is really a controversial area, and is probably, would be a good area for a prospective study, to tell us, the advantages or the potential complications of using, multifocal IOLs in children.
Thank you. Regarding we have a lot of cataracts in Saudi Arabia, and most of the time we don't do further investigations or further studies, no? So any advice because we have international audience, so any advice for the investigations of the cataracts in children?
To be honest with you, I think we should investigate everybody, or have them investigated by a pediatrician, for example, a geneticist, or a metabolic disease, because invariably there must be a reason for this. And this could be really like the presence of the cataract, and the management of the cataract could shed the light onto the general condition of the patient that might be sight-saving or life-saving, for that matter. Certain metabolic disorders, if not caught early, could really like impact the whole life, of a child. So in general, yes, we do them and we have, very good experience, good, surgeons in handling cataracts, but we should not really close our eyes about the general condition of the patients. And, we should really either ourselves or, refer the patient to somebody who has the experience and the capability to do the proper workup for every cataract patient.
Regarding the aphakic patients, what do you think about artisan artiflex iris clip IOLs?
Can be very useful in certain situations where you don't have really enough capsular supports. However, the nature of kids being much more active and so on makes me a little bit, careful in selecting my patient for this procedure.
And regarding the scleral fixated IOLs?
You are the expert, Prof. I have seen several of your patients, and I must really compliment you. Really, the ones I have seen, I've followed for now a couple of years. They're doing very well. And, more and more, as I said earlier, it's an individualized, care for the patients. In desperate situations, yes, I would go for a scleral fixated IOL, for an optimal visual rehabilitation. It's not my first choice, sure.
Any special tweet for the drops in the post-op?
You are the expert. Maybe you can do the tweet this time.
No, I mean, any consideration regarding the drops, for example, dilation drops, or any.
Dilation drops is important, like any other cataract surgery. However, in certain situations where we fail, the pupil fails to dilate, one might resort to iris hooks at the time of surgery, intracameral lidocaine with phenylephrine is also very useful. Especially we have them prepared for us here in the pharmacy fresh, without any damage to the intraocular structures, is very useful. Post-operative care is very, very essential, especially knowing that kids react to surgery very aggressively, with pouring out a lot of fibrin. So the immediate post-operative care is really very, very, crucial for the final outcome, with frequent topical steroids. That's how I would really see it.
We have a lot of pediatric ophthalmologists with us today. Anyone is invited to make some questions to Dr. One question regarding the glasses in the post-op. I mean, any special consideration for the refraction? Are you using bifocals in kids? No using bifocal? What is the age? Because also we have residents with us, and so as a guidelines in the prescription for glasses in the post-op.
Thank you very much. This is really very important. As we said, it's not really only a successful cataract surgery. It's really ultimately an optimal visual rehabilitation of the child. An optimal visual rehabilitation is really optical correction is really like the most important part. So post-op refraction, I really discuss this with the parents before the surgery and see their, appetite for glasses. There are many people who really would not really think of an eyeglasses post-operative. And for somebody with a unilateral cataract, especially if I aim for a hyperopic, refraction post-operatively without correction, is equally amblyogenic. So I discussed the need for glasses pre-op with the parents, and I stress on that. And the use of bifocals is really also very important. in order for these kids to be optimally visually rehabilitated. All of this really is essential parts of the management of patients with cataracts.
Dr. Amal is having 3 questions. So, Dr. Amal, do you want to, will you make on and say the questions to Dr. Awad? Dr. Amal?
Yes, salam alaikum, Dr. Abdul. Thank you very much for your informative lecture. I just sent few questions on the chat. What is your regular post-op medication regimen for your pseudophakic patients? And do you have any experience with the yellow tinted IOL? Because I have noticed some of the patients, family, they are they got a little bit concerned about the shining, you know, the little shine, the crystal-like thing that you see in the patient's eye after IOL. And I had patient concerned about this. So have you ever used the yellow tinted intraocular lenses?
Thank you very much. Very important, valuable questions. Starting with the post-op medications, as I said, you know, invariably we do need more frequent topical steroid medications. In general, my preference is Q4 hours for the first, you know, prednisone acetate, pred 40, Q4 hours for the first 2 weeks, and then, you know, taper them over the coming, you know, month, going, you know, a week, you know, tapering every week. Regarding the yellow tint, invariably, you know, all the acrylic IQ IOLs are yellow tinted. And yes, I've had several patients, just like you, Dr. Aman. You know, they are, you know, annoyed by the reflections, you know, of the IOLs in their eyes. And, you know, I reassure them, this is probably, you know, like, you know, the limitations of the industry at the moment. Hopefully, you know, with better material, this would be really over. You know, the post-op surprises, you know, as I said earlier, I always talk to my patients about, you know, the use of eyeglasses post-operatively. Fortunately, you know, we don't really have that much of really big surprises. However, if it does happen, you know, I would manage them just like any refractive, you know, error. An exchange of the IOL is also a possibility, and you know, in our case, we can really. I have exchanged IOLs, but years after the implantation, where they really began, you know, very much into myopic shifts. I have really exchanged IOLs with success, no problems with that.
You know, this is interesting that we don't have this issue about the surprises in KKH. You know, I don't know if it's because the way that I mean, as frequent as you can see in other places, I don't know if it's the way that the technique to do the biometry, we don't face a lot of, we have these surprises, but it's not frequent as probably before or years ago. I don't know if because it's related to the technique that we use or no, but as you mentioned, usually we don't have problems also to get access to the OR and exchange the IOL if it's necessary. You know? I mean, but it's not something that fortunately is not frequent for us. There is a question from Mohamed Khalifa that about the use of intracameral triamcinolone at the end of the case. What is your opinion?
Thank you, Mohamed, for a wonderful question. You know, I do use intracameral steroids at the end of surgery, especially in the young ones. It really, really makes a big difference in the outcome, and especially, you know, if I have some doubts about the reliability of the use of post-operative frequent steroids, it's actually very, very useful. when you do you use them, you always like, you know, conscious about post-op, high intracurvature steroid responders. I must say, you know, very few patients, and it's in general a benign condition. That's at least my personal experience. Once I stopped the the steroids with adjunct glaucoma, topical glaucoma medications for a couple of months, this usually really like disappears, and that's my thing.
Dr. Rubio has a question about the toric IOLs.
Toric IOLs have been reported in children, and it's actually useful. My only thing about toric IOLs is that astigmatism in children is changing, so I'm not a big fan of it. However, it has been used with success, especially I would say in an older child with a cataract and significant astigmatism. There is certainly a place for toric.
I think that one of the issues with the toric and with the multifocal IOLs is the issue of the meridional amblyopia. This is probably the most important issue regarding the use of this, especially in younger children. No, I'm agree totally with you. If it's an older children, we can have better success rates with the torics or with the multifocal. So, any other questions? So, well, if there is no more questions, I would like to thank to all our guests, and especially you, Dr. Awad, for this very informative lecture, and all the guests that join us today for this very, very nice lecture. And we'll see you next Tuesday in the Grand Rounds. Thank you very much to all of you.
Thank you very, very much, Paul. Thanks.